Okay, well, guys, welcome back to the Crave Show with Chris and JRuss, and our guest
Was
this
that
week
you,
is.
Kyle?
No, I did not.
Who was that?
Okay, Kyle Barbour is our guest. So we're always talking before we get on, and there's some nonsense. But Andy Locke, my teammate, he does that like if ever there's a quiet moment, or he does it all the time. He just.
Well, that was you, JRuss?
Yeah, that's. Like,
I thought it was
don't know where he
Kyle.
got it. No,
Dude, that
but
was
like
hilarious.
every time we're taking a photo or we need to laugh, Andy will bust that out. It's hilarious.
That's awesome.
Okay, so before so all right, before we sign on, if I didn't say it clear enough, this is Kyle Barbour. He's going to be our guest this week, and Kyle, I'll give you a chance to tell everybody who I are in a second. But we're talking about birds, and Kyle's girlfriend Emily. Go ahead.
So she volunteers with a raptor rescue in
Nice.
Rochester, New York, called Wild Wings. There's a bunch of great photos of Emily with falcons and hawks and things like that on her wrist. And her and a bobcat. I'm not entirely sure why the bobcat is in the raptor rescue, but a really dope bobcat. And my favorite fact about this that I learned from her is that they can hear your heartbeat. And will mess with you to intimidate you, and that they will not respect you or be trainable if they hear your heart rate increase.
I've been saying they're smart. I've been saying.
Yeah. Apparently, owls can hear like mouse heartbeats under multiple feet of snow from quite a distance. Impressive beings.
Dude,
Man.
that's insane.
Yeah,
You guys, we
super
don't
cool.
know anything. We know nothing. It's amazing.
That's wild.
Huh?
That is wild.
Okay.
That's cool.
Kyle, who are you?
Well,
You've got 10 seconds, Kyle.
No. You got as long as you want.
I think germane to the reason that you asked me to come on here, I'll talk about myself professionally first. So I'm an emergency physician. I've been working or volunteering in some aspect of the emergency services for most of my life. I spent about 11 years in volunteer mountain rescue in California and working in the emergency department there. And then my current role is that I'm assistant professor of emergency medicine at the University of Vermont. I work in the Division of Rural and Population Health. And in that role, I'm responsible for clinical care and of patients largely in extremely rural, very high acuity hospitals, where I'm the only emergency doctor. It's me and 3 nurses with everything from regular aches and pains to the sickest, most critical people you've ever seen. And I teach residents how to manage that by themselves. Yeah, Chris.
Okay, wait, what did you say? What did you say? Acuity? What did you say?
High acuity. So the hospital I work at is super busy and people are really sick.
Okay.
So I work in my main shop.
So like acute.
Yes, highly acute patients. So my main shop is in a critical access hospital, meaning very, very rural. It takes helicopters or planes or 3 hours by ambulance to get someone from there to somewhere else. And the cavalry is not coming.
Okay.
So it's me and 3 nurses and a tech, and we take care of everything that comes through the doors.
Wow.
And I teach residents how to do that. And my clinical focus is largely on rural emergency and trauma care, and then I also do a fair amount of substance use disorder work. So that's what I do professionally. And then as a skydiver, there's not a ton to say. I'm a baby bird.
No, that's not true.
I started in paragliding, and I learned about skydiving a long time ago and base jumping, and knew that parachutes were going to be a part of my life, but it took a really long time for me to be in a position where I could do some. And I've been in the sport for almost 2 years now, and I'm just totally obsessed. I fell in love with it immediately, and my heart and my mind is always trying to get in the sky. I just love it. But I'm not a particularly notable skydiver. I don't think that's why you asked me to come along.
Well, okay, but we're gonna talk a little bit about that, and other people can be the judge because I have some things to share about that as well. You got any questions, Chris? How you doing?
I mean, I got a ton of questions, but go ahead, man.
No. Let's go. I'm just gonna get back to Kyle.
Yeah, I mean, I'm going to get us sidetracked because I want to hear about like the hospital and all that crazy care. Like,
Yeah.
I want to
Yeah,
hear
man.
wild stories, but that's going to get us off track. So you go ahead, JRuss.
Oh, there's no track.
Okay, come on, give us one crazy story. We got to hear
Yeah, yeah.
one. Is there something that comes to mind?
I mean, it's just a wild, wild place. I mean, there's no help, and it's very rural, and there's a large catchment area, and there's a lot of sick people. So the place is very interesting. I work at a hospital called Alice Hyde Medical Center. It's very close to Canada. Near us is a large native reservation. It's the Mohawk Reservation. 3 of New York State prisons, a large Amish and Mennonite population, and a lot of farming and some mountains. And the constellation of those things generates a lot of illness and a lot of trauma. And there's absolutely zero support. It has to get managed by me, or it needs to get shipped.
Okay.
So,
have you ever had a patient that you thought there's no way we're going to save this person, and then somehow you did?
for sure, but I have to say, it's just not the way that we think about it. It's like when I get a really critically ill patient, someone who's had amputations from a traumatic injury, or they've delivered baby. We had a twin delivery in my first couple of weeks there, and both of the patients needed, in fact, all 3 of the patients, the mother and both children, needed extensive resuscitation. What ends up happening is you can just feel, maybe it feels a little bit like exiting. I feel time slow down, I feel the volume turn down, and everything just 5 minutes feels like it takes an hour, and you're just entirely in the moment until it's over. And I don't spend any time thinking about what the likelihood of success is. I spend all of my time on meaningful interventions, if that makes any sense, and coordinating the team.
Yeah.
I mean, there's so many stories that just come to mind. You could go on forever and ever, whether it's prison riots that we've dealt with there, or the twin delivery with 2 not breathing babies and a hemorrhaging mother, or my colleague who just had a traumatic amputation of an arm that she resuscitated after someone rolled their vehicle, or the many, many, many other ways that people die in northern New York and rural Vermont.
Wow, that's wild.
It's a wonderful place to work. If you like extremely intense emergency medicine, you should give us a call.
So when you get in the middle of one of those situations, do your brain and your mind, like everything just zeroes in, focuses on the task at hand, and does everything else disappear? Like that's the only thing you're thinking about?
For the most part, when I'm in high intensity resuscitations, it's among the most profound flow states I've ever been in. It's part of why I love emergency medicine so much. There's an incredible intimacy with the patient, and we go from having never met each other to having extremely intense experiences together instantaneously. And there's a combination of doing the right things clinically, helping your team be oriented towards a successful outcome, bonding with the patient emotionally and soothing them and helping them believe in you and believe in the team and feel safe, and taking care of all the other people in the emergency department and managing the department. And I just love that. It's an incredibly powerful experience. It's hard to put into words, but I think jumpers in some ways are keyed into it, because there's something that reminds me very, very much of beautiful skydives, where, I'm not, the second I get out of the plane, I'm just in a different world. And there's no, that 35 seconds feels like 5 minutes. And the emotional connection that you share with the people on that jump is so beautiful and so profound, and creates these really intense and meaningful relationships. And I feel that very much with my patients and with the nurses and technicians that I work with. It's a beautiful thing.
That's cool. Well, I think that you were designed to do that. No, I'm serious.
Thank you.
I don't think everybody. I think there are certain people who were designed in a specific way to be able to handle those situations. The gifts and the talents and the way that you were created actually made you so that you can serve and bless people and care for people in that way, and give love in a very special way that other people can't. And that's just so fantastic.
Well, thank you. I'm honored. It's a privilege to get to take care of people.
Yeah, that's cool.
Okay, I'm muting myself because the AC's on.
I was wondering. It got so quiet. I was like, "Oh, there."
It sounded so peaceful for a moment.
I'll mute myself as soon as I fire questions. So, Kyle, I know you had kind of an interesting story as far as your educational pathway and non-traditional, I would say. And I find that really interesting, and I think Chris and everybody else will too. And you told it in a sort of a funny anecdotal way of like, you got in med school and then had to sort of retroactively deal with the admissions department over nonsense from your past. And so if you wouldn't mind sharing that with the world, I thought it was a fun story.
Sure. So when I was young, I didn't have a lot of, I didn't do well with authority, and I didn't like being told what to do. And this resulted in, and I thought a lot of my education was really useless. And so I dropped out of high school when I was 15 and spent the time that I was going to be in high school working in Northern California as a handyman and lumberjack. So I did that, and that led to some strange things. And I worked in a lot of different countries doing relief work and odd jobs. And when I came back, I had gotten really into rock climbing, and that set my life on a new pathway. I went from that and started getting really, really involved in search and rescue. And from search and rescue, started to be interested in medicine because I was working with all these nurses and paramedics and wilderness medicine doctors that I thought were just incredibly inspiring and beautiful people, and I wanted to be like them. And I saw what they did for people, and I wanted to do that too. Which led to some problems because I didn't have a high school diploma. So I started going to community college and transferred from community college to UC Berkeley. And when that happened, they called me, well, they accepted me and then called me about a month before school started. And they were like, hey, you don't have a high school diploma. You're supposed to have that. That's important.
I was gonna say, you got into Berkeley without a diploma? Like, what the heck is that?
Yeah. And I said, well, I disclosed, at the end of your college application, there's always that section where it's like, is there anything else you would like to tell us? And I said, I don't have a high school diploma and I'm not going to get one. And so that's that. And and I said, well, I told you all of that. That sounds like a you problem. It doesn't sound like a me problem. And they said, well, we're going to have to put that on your transcript. It's like, put it wherever you want. So on my UC Berkeley transcript, right next to graduated with highest honors, it says no evidence of high school graduation.
That's fantastic. That's great. Like, I love it.
When I was in California, the community college requirements are that you be either a high school graduate or capable of benefiting from instruction. That's the text. So I'd been working there for, I'd been working and studying there for a year or two, and they revoked my financial aid. And I went into the office to say, hey, can we sort this out? And they said, well, you haven't proven that you can benefit from instruction. It's like, well, okay, that's fine. But just so you know, you're currently paying me to teach calculus. So can we move on? And they're like, okay. And they reinstated my financial aid. That's These wild. Days, now that I have a doctorate, I don't have to deal with these kinds of problems. But
oh, dude, that's pretty awesome.
It was great.
So you still don't have a diploma, right?
No, I do not have it. There's no evidence that I didn't graduate from high school.
Yeah. And no plan to go back.
No.
Yeah. That's great, man.
High school sucked. I
from
zero desire to do. I was just getting in arguments all the time. It was like, I remember having a class that I had some conceptual disagreements with, and I went to the professor at the beginning of the course and said, I think it would be easier if we could just have an agreement where you fail me and I go study math because that's cool and I don't want to do this. And they insisted that I come to class every day. And so I came to class and tied nooses in all of the curtains, and that upset them. And eventually I said, well, we can always go back to the agreement that I proposed at the beginning of the term. And that was when I dropped out of high school. I've become a little bit more tempered in my life.
That's good. Moderation.
The angst of a 15-year-old.
Oh,
I'm not defending this. I'm just saying it happened.
Yeah, no, you're just stating the facts. Love it.
Okay, so let's get to a point where we can contest your statement about your skydiving pathway. So you started jumping, it's only 2 years ago?
Yeah, I got licensed on September 3rd of 2023.
Okay. And were you in Rookie Fest that year?
That was when I came to, I came to Skydive Chicago because I was trying to get licensed in New York, and I work weekends and nights, and there's limited instructor availability and weather, and I just couldn't do it. So I came to Skydive Chicago, and just completely fell in love with it. And I believe it was Bethany at the gear store who was like, "Hey, man, you're one of us, and you have to come to this event. You have to come to Rookie Fest." I was like, "Well, I'm working all weekend." She's like, "I don't care. You gotta do whatever you gotta do to get yourself to come to this." Like, okay, understood. So I did, and I think I came to Rookie Fest with like 30 something skydives, and man, that changed. I met Steph, and yeah, that changed everything. I remember going up to her. I mean, at that time in my skydiving career, I was just so in love with it. I was like crying every time my parachute opened because it was just so joyful, and I would just be like laughing and like tears coming down my face in the landing zone, and just completely enraptured with it. And I remember Steph was one of the I don't know, LOs. I don't know the right coaches. I don't know the right way to put it. And I remember going up to her and saying, like, "I love this. I want to do what you do. How do I do that?" And she said, "Have you heard of the tunnel?" And that changed everything.
So you're 2 years in. Kyle has attacked the wind tunnel, I would say. You're 2 years in. You've gotten a bunch of coaching from Steph. You're doing quality VFS with a couple of 3 people from Skydive Chicago on a semi-regular basis.
Yeah, so, Lynn, Kripp, and Kevin and I hit the tunnel and do VFS together pretty much whenever we can, although it's hard to get us all together in the same place given our schedules. But joyful when it happens, for sure.
Yeah, getting 4 people together is always a challenge.
It's hard.
But so for the people that listen to you say, I don't know exactly remember your verbiage, but something along the lines of "my skydiving is nothing to write home about." After 2 years, you're flying comfortably on your head in the tunnel and the sky, doing VFS, and you've got transitions from head up to head down. Am I getting that roughly correct?
That's true, but like anyone who goes to the tunnel can do that. I'm just very fortunate that I'm in a position where I can go to the tunnel.
No, not anybody who goes to the tunnel can do that. I know. No,
all right. You guys are the professionals. I'll take it from you. But
I know tunnel instructors who have been instructing in the tunnel for more than 2 years and can't fly head down.
So there was a guy at Skydive Chicago, and I don't want to call him out because he's a super nice guy, but he works in one of the Chicago tunnels, and I believe he's been there 6 years. He cannot fly in his head.
Yeah.
I guess where I'm coming from is one, I am completely in love with falling. I just want to spend my entire life in free fall if I could. My one criticism of the sport, or my biggest criticism of the sport, is just how financially dependent it is. And it makes me super, super sad because I have lots of friends that I would just love to share this utterly joyful experience with, whose financial circumstances make it really hard to progress. And I don't view my skill set as being particularly impressive or whatever, because I'm very fortunate. I haven't had money my whole life, but I do now because I'm a physician, and I try and spread it and share it with others and share the joy with other people and all that. But it basically comes down to like pay to win on some level. And so I don't think that makes me exceptional at all. It makes me very fortunate.
Yeah.
Does that make sense?
Yeah, absolutely. And I think that's a very, well, that's a humble thing to say, but also fair. But what it does mean is that you have the desire and you've put in the work, like you've tried.
Sure.
Because those people, those instructors that I know that have been instructors for more than 2 years and can't fly head down, it's not because they can't. It's just because they haven't tried, and they haven't tried long enough. They haven't put in the work. Go ahead, JRuss. What you got? Something?
Well, I was just going to say that you hit that on the head. Like I've jumped with very wealthy people, and they didn't put in the work, and they didn't put in the effort, and they didn't put in the time, and money was not. I mean, I agree that skydiving, there is a barrier as far as the finances go. Like at $35 a jump ticket and $2,500 to get through AFP, and AFP is the extended program at Skydive Chicago. It's not just AFF. It's like a 18, 20 jump program, something like that. But much more thorough than a regular AFF program. You know, $5,000 for a used rig, travel, tunnel time. Like it does add up. But man, I've jumped with a lot of people that was a drop in the bucket of their life, and yet they don't have sort of the stones to see it through, and that's an important point.
Yeah. Yeah.
One of the things that I wanted to talk about with Kyle was at Summerfest. And this, I don't know how deep we're going to go in this rabbit hole, but at Summerfest, there's another doctor who's an organizer, Doc Tom. And Tom has also done emergency room work. I don't think that's where he's at right now. I think he's kind of moved on from that into more of the management side, but he could still be doing it. But he did it for a long time. He still
practices clinically.
Okay. And he was, I believe Tom was a Marine, and was became a surgeon in the military. Tom's going to be on the show in the upcoming weeks for similar but different reasons. But anyway, there was a guy at Summerfest who was not an emergency room physician, but certainly had the attitude that he was aware of some of the vagaries germane to being a emergency room physician, and tried to lecture, I think, Tom and Kyle about those issues in our healthcare system. And a somewhat testy conversation ensued, at which time I think both of the actual doctors just said, I don't want to misquote you guys, I'm going to make this up, but it's along the lines of, "You're an idiot, and I'm going to stop talking to you." So I was curious because I asked Kyle about kind of the content of the conversation, and more than the funny anecdote is the thoughts that Kyle had about kind of where they were headed with that conversation. So I think that, again, is a topic that lots of people would like to hear about, if you don't mind sharing that.
For sure. Very briefly, I just want to mention that jumper came up to me later, and we chatted and cleared the air and are in good terms, and he's been nothing but kind and thoughtful to me, and I thought that was really respectable. So if he happens to hear this, love you, buddy. Would love to jump with you another time, and maybe we'll have a longer conversation. I don't want there to be any hard feelings about it. But I believe the conversation was roughly of the form that this other jumper felt that the American medical system provides some of the most stellar medical care in the world. And Tom and my perspective as practicing physicians is that the American healthcare system is just abysmal, bad on almost every metric. And I can get into great detail about that. And there, I do want to acknowledge a kernel of truth in what this other person was saying. It is possible, if you have money and privilege, to access some of the finest medical care that's available in the world, that is present in the United States. But the medical care that you're going to access, if you're a normal person, is deeply compromised and extremely expensive. And there are deep structural reasons that is the case. And it is harmful to an incredible degree to the people who work in the system and to the people who need it. And that is a source of constant anguish for me. It's a source of constant pain for almost everybody who works in this. I don't know any doctor who is practicing clinically, especially in a front-facing specialty like emergency medicine, who feels that this system is serving patients well. And our leadership on both sides of the aisle are constantly making decisions that deeply harm patients. And a bill was recently passed that removed 1 to 2 million people from health insurance in my catchment area, and that is going to have catastrophic consequences. It's going to have catastrophic consequences to those people, and it's also going to have catastrophic consequences to everybody else. And I can get into some detail about why that is, but the short version is that just because someone is not insured does not mean that we don't pay for it. It's going to get paid for one way or the other. It's just going to get paid for in an incredibly inefficient, extremely cruel, and brutal fashion. And so the position that Tom and I were coming from, and I don't want to represent Tom's opinion, although I believe that he and I broadly agree, is that we are living in the wealthiest and most powerful nation in the history of the world. And we would like to see that wealth and power be used to the betterment of all people. We want that to be distributed in an egalitarian way so that people can live lives of dignity and meaning and purpose, and not be constantly struggling to make ends meet and have the incredible harms that our health system impose on people. So that's the conversation in a nutshell.
So what if I mean, if this is a too big of a question, you can pass. Is there one thing that you like? What needs to change? I mean, but if I'm going to get us way off into the weeds,
no,
like, can you pick like what's the big thing? What's the most? You know what I'm saying? Like, what do you?
There are many problems, and significant change on many domains needs to occur. However, the one fundamental problem that is the cornerstone that causes all of the other problems is that we run a for-profit insurance system, and that we minimally regulate that for-profit insurance system.
Okay.
The United States is the only country in the world that pays more to health insurance than it does to clinicians.
Jeez, dude.
There is your money, your tax dollars, your insurance payments, those things largely go to denying other people medical care.
I don't understand what that means.
Well, the role of health insurance, especially in a for-profit insurance system, is to not pay you. Every dollar they don't spend on you is dollars that their executives get to keep and their administrators get to keep.
Okay.
So they're strongly incentivized to deny claims and restrict access to healthcare.
Huh.
And when you're paying for health insurance, you're paying the salaries of the people who do that work.
Gotcha.
And there is no pathway forward that does not that would be clinically successful that does not involve the abolition of this system. It's that simple.
What is my option as a regular person? Can I just quit having health insurance?
No, unfortunately, you should definitely have healthcare insurance if you can have it. But I think it's very important that people understand the real nuts and bolts of what a universal healthcare system would look like, and understand that there are both that it is both from a left wing or from a right wing perspective the superior system. It is cheaper, it's more efficient, it distributes resources more equitably. It would remove an enormous sector that's entirely waste and bloat, and would allow us to reorient our healthcare system towards the things that really matter. It's important to note, switching to a universal healthcare system, and there are many ways that can be structured, would not resolve all of our problems. We are in a deep hole. We've created problems over nearly a century, and it's not going to take just some legislation to fix that. It's going to take time and a lot of work. But it would be very, very helpful if we started to orient people's consciousness and started to have people in a position of power whose orientation was not towards healthcare insurance executives and hospital executives, but towards the welfare of everyday human beings.
Does universal health care, does that have to be government subsidized or government run?
It does not, actually.
Right.
I think there's a lot of reasons for that to be that would be the more efficient and effective system, but it's not the only way to do it. So let's look at a few different models.
JRuss, is this what do you want to?
This is exactly it. So
okay.
I'm super happy with your questions, and this is exactly what I want to talk about. I think that when I was standing around with Kyle and Doc Tom, both friends, both people that I know care about their patients and care about medicine, and even though Tom's direction is slightly different than Kyle's, I think the perception sometimes among non-healthcare professionals is that the system is rigged and everybody's in on it. And I think that I agree with the first statement and I disagree with the second.
100%.
But yet that's not the perception in my opinion. I think that but just standing around and listening to these guys talk to each other, and kind of I was in the conversation, but mostly they were just chatting to each other about the ills of the system and how it's structured and how they're as trapped as anybody else as far as like the knowledge that it needs to change, but the impotence to do anything about it on the bigger scale. At least if I was hearing all that correctly, and And so I thought that was a super interesting conversation to try to retell to everybody, because there are people who are corrupting the system, but then there's a whole bunch of healthcare professionals who genuinely want to help people. That's what they started doing it for, and sadly, those numbers are declining because people like Kyle who just want to help other people, and hopefully there's a reasonable paycheck at the end of it, and they're not doing it for greed. They're doing it because it's what they want to do. Those people are going elsewhere, and we need them to be doctors. I think numbers are down for medical school enrollment more than 30%, and it's a tragedy. But people need to hear that it's happening on both sides of that fence, so that it doesn't get to be that regular people who need healthcare are angry with doctors and nurses. That's not the thrust of where that energy needs to go.
I totally agree with you. Getting angry with your doctor or nurse about the brutal and unfair healthcare system that you're forced to endure is analogous to getting angry at the airline clerk for your airplane being delayed. There are structural reasons that have led to airlines being less efficient and worse and a lower quality and higher risk experience for everybody, and the clerk is not in charge of that. And I understand that physicians and to some degree nurses and other healthcare professionals are well paid and stable and appear like authority figures, but I am not in charge of this. The White House is not calling me and asking me for my input on how to run the system. And it keeps me up at night. I have so many memories of watching people die, literally, not figuratively, but having my hands on them as they died as a result of for-profit healthcare decisions. It's that simple. And my simple way of, simply put, medicine cannot be about profit and be successful. It just isn't. It's a service, and it's something that's essential for a dignified and secure life. And it's something that if we run in a capitalized way where it's about profit seeking, it leads to incredible inequity. And we're experiencing that right now.
When you said like having your hands on someone that died because of insurance decisions, maybe,
sure.
And I'm misquoting you probably, but
Okay.
you, I mean,
give an example?
Yeah, you got to
Sure. Yeah, exactly. So I graduated from residency and began my clinical career at the end of the COVID pandemic. It's like I was in residency while COVID was in full swing. And so I experienced that in sort of the second half of my training. And then I entered the workforce when it was still pretty bumping. The hospital that I went and worked at is one of the busiest hospitals in Western New York. Probably the busiest hospital in Western New York. We see over 100,000 emergency department visits every year, lots of trauma, lots of gunshots, very sick people in an incredibly impoverished area. And emergency medicine just isn't super profitable. And so what that meant is that I worked in a inflatable tent in the hospital parking lot that was leaking snow and propane and water. There was no way to wash my hands. There were 70 patients propped up in folding chairs. There were 2 nurse practitioners with no emergency medicine experience who were moonlighting as nurses, and I was in charge of that and trying to keep people from dying in that environment. I have a vivid memory of a elderly Black man who was in respiratory failure and whose last words were literally, "I cannot breathe. I can't breathe. Please help me." He was begging me, and he died while I was fighting with the hospital system to get him on a monitor and get him in a bed. And I resuscitated him, and he ultimately died. Or I tried to resuscitate him, and he ultimately died. The last person who touched him was me. And when I complained about this to say that this is a deep injustice and is totally preventable, I was absolutely capable of saving this person's life if I could just have the tools and put them in the space that they needed. I was told, it sounds like you did all the best you could. No change needed. File closed. And that was the end of it. And if you don't like it, your contract has a 90-day out, so feel free to find work somewhere else. And that is the way that for-profit medicine sees you and sees me. It's not oriented towards the welfare of everyday people. That man was probably not going to pay his bill. It's not profitable to provide him healthcare. It's way more profitable to have, low-risk chest pain rule-out units and expensive stroke centers that excite donors. And it's not at all exciting to do the simple work of medicine. And
Wow.
the real work of medicine is connecting with people, listening to them, touching them, hearing what they need, negotiating problems, following up with them, troubleshooting, empathizing, helping people feel safe and that they come back. And that's time consuming. It cannot be done to the sound of a buzzer. It can't be done in scheduled 10-minute visits that abruptly end the second a new patient comes through. It can't be done when we deprive primary care physicians of meaningful incomes and we turf everything to specialty care into the emergency department. And when we fill the emergency department with boarders, meaning patients who should be admitted or be transferred somewhere else, but those things aren't profitable, so we don't support those things. Meaning that my emergency department is filled with non-emergency patients and my emergency nurses are taking care of non-emergency patients. And that means that when I have real emergencies, I resuscitate you in the waiting room and you may die as a consequence of that. And I've seen that happen over and over and over again. That is the state of medicine in our country. I spent, before we were on the podcast today, I was in communication with my specialty organization, the American Academy of Emergency Medicine, who's working on publicizing these stories and trying to build attention towards the political and social problem that is American medicine, because it's not a medical problem. I know how to treat patients and my colleagues know how to treat patients. We just can't do it because the system doesn't work in benefit of patients. And it doesn't work in benefit of patients because it's not profitable to work in benefit of patients. And if we want it to serve patients, then we have to accept that it's not profitable and accept that this is an important service and subsidize it. And it turns out, thankfully, that if you do it that way, it's actually much cheaper and more effective than what we currently do. It's just not profitable to the people that are currently in power. It's better for everybody, except for the people who are currently laughing all the way to the bank. So the hope in my heart is that there are more of us than there are of them. And our cause, which is the dignity and welfare of people and the compassionate, loving drive to have everybody live dignified and healthy lives, is just a much better cause than their greed.
Man.
But we can't win if we don't help people along the road and understand what this is. And I think it often gets turned into a rather silly political issue and what I mean by that is like whether you're on team blue or team red.
Mm-hmm.
And it really isn't. It is both kinder and more socially progressive and more humane, which is maybe the more blue coded argument, but it's also cheaper and more effective and more rational, which is maybe the more red coded argument. Everybody wins except insurance executives, and who fucking cares about them? They're the enemy. Like, we have to beat them. The point, I want to be kumbaya, but not with them.
Okay. Well, I got to say something, JRuss, and then you go ahead, please. But okay, for our audience, I know that this is not the typical show.
We can talk about about movement, exit order.
No, what I want to say is, okay, if you're in the audience, if you're listening, I mean, I know our audience is small compared to like Joe Rogan or whoever, but maybe there's somebody, if you're listening, there might be somebody that can actually do something about this, like can actually help Kyle and help some, I don't know. I'm just saying, like, that's what it's going to take, is people from all different places, all different walks of life, like getting together and working, saying, okay, we're going to try to help do something. We're going to try to take steps forward and do something different. I have no idea what that means, but it's very inspiring listening to what you're saying, Kyle, and encouraging to hear that there actually is a way forward, really, is what I mean, you said there's not, but when you talk, I hear that there is. There
is a way forward. We are in a very challenging political environment right now. I don't know, regardless of what your perspective is on where we ought to go, I don't know anybody who feels that the system right now is serving them.
Yeah.
Or feels, oh, hey, hi, Bean.
Oh,
we have a visitor.
Right.
That's so delightful. I love it. So very few people feel like they can have their voice heard and that they can make a difference so that they know the path forward. Mm-hmm. But there are some really positive things. One is that we're not doing this for the first time. We're the only industrialized country that does medicine this way. So we can look to our neighbors and see what problems they have had and why they have had those problems and the systems that they have created and how we can translate that to us. The German model, for example, you had asked earlier, does it have to be government subsidized? It has to be government regulated, because it needs to, like, it's not acceptable that we have like these high deductible healthcare plans. They don't cover people. It doesn't solve the problem. That's not a way forward. And the only way through that is some sort of regulation if you're going to have a non-governmental program. But for example, the German model uses private insurance that is tightly regulated and is mandatory. And it's not, you don't have to go through a complex Obamacare style enrollment process and get fined to do that. You will just wind up on a plan. But that is one way of doing it, where there's a private public partnership. There are other programs where it is exclusively government sponsored. And there are other programs where there's some degree of hybridization. So when you have a universal healthcare system, in general, if you are having low importance problems, you are prioritized lower, which I think is clinically appropriate, but can be bothersome for people. And so in these hybrid systems, you can get insurance that would allow you to seek people care faster or get certain kinds of things that might not be, maybe cosmetic surgery, for example, or cosmetic procedures, that would let you gain access to that without paying for it. But everybody is covered for the fundamentals.
Kyle, would you agree that that's more like a UK system, if I'm hearing you correctly?
I believe that that's true, but the NHS has gone through, the National Health System, or NHS is Britain's system, has gone through some changes of late, and I haven't kept up to date on them, so I don't want to. I believe that is how the UK does it, but I don't have all of the data at the tip of my mind. I do want to address one thing that I think is a common criticism, which is that Americans are often quite concerned about deservingness. And there are, the concern is often raised of, I don't want to pay for someone else's bad habits. And so I would like to raise two rebuttals of that, because I think it's important to at least acknowledge that. The first is that there are truly some very difficult human beings out there, and I come into close contact with them every time I go to work. So there's a lot of violence and a lot of harm and a lot of substance use and a lot of difficulty. However, the first thing I would say is that we're going to pay for that anyway. It's when that person doesn't have health insurance, they still come to the ER, which is the most expensive place to get healthcare. And where does that money come from? Well, the hospital will provide the service, and it will try to get collections. And when it fails to get collections from other people, the hospital sees that on its bottom line, and it raises costs for everybody. So ultimately, your insurance is higher, and we pay for it anyway. The only way out of that is to be in a totally barbaric society in which we just accept that some people will just be executed or die in front of you on the street. And I'm not willing to live in that world. I don't want us to go back to that. So we are going to pay for it. We're just going to do it in a crueler, less efficient, less kind way. And the second thing that I would raise is that fundamentally, medicine is not about promoting virtue. It is about protecting people from their vices. And that is as true of the opioid-using diabetic patient that doesn't take their medicine and comes into the emergency department as it is of the swooper that pounds in. Someone out there is going to say that's their own decision, and I don't want to support that. And we are better off. It is cheaper. It's more effective. It's better for everybody if we can put our judgments aside and look at what actually works. Measure the system not by our judgments of right and wrong, but measure the system by its cost and its efficacy. And everywhere that has done this has clearly found that the universal approach is better. It's cheaper because we get to completely eliminate all of the waste and bloat that comes with health insurance, all of the calls that I spend arguing about MRIs, all of the administrators whose only role is to try and eke out dollars from patients, all of the collection agencies, all of that just goes away and we don't have to pay for it. And That decreases cost significantly and it improves efficiency significantly because there's one set of rules that works for everybody, and I learn those rules, and then I can get you that MRI, or I can get you the CT or the test, or I can see you and tell you don't need those things or don't meet the criteria, and we have a more streamlined approach that works for everybody. There's an enormous amount of money right now that just goes into figuring out like which people qualify for what and what they can get billed and deal with all of that. And any of you who've ever encountered the system just knows how abysmal it is to interact with it. And it's abysmal for me too. It's just awful. And I don't want someone to go have a traumatic brain injury and then get kicked off their insurance because they can't navigate that system. I don't want someone to be unable to work because they have to be under the income cap for Medicaid. And if they go over that income cap by having employment, they lose access to their cancer drugs. It's wrong.
Yeah, it's really, yeah, it's messed up.
So there are many ways. Sorry, go ahead, JRuss. I'm sorry.
I guess, I mean, we're 3/4 of the way into a normal length of podcast.
Sure.
And generally speaking, I think that on some level, a lot of people are familiar with some of the stuff that you're saying.
For sure.
Maybe not as fleshed out, and certainly not as much of the picture, but people see little bits in their dealings with insurance companies and getting denied for cancer or whatever, that when they really need the care the most. And Chris used an expression that I really like of a pathway forward. And so a lot of times when I'm having discussions about anything that's problematic, what is the pathway? And it seems so complex to the normal person. The universal health care, is that synonymous with single payer?
Let's say yes for simplicity. You could raise some quibbles, but functionally yes. You have to have a single payer or a universal approach or regulation that makes it functionally single payer, even if there are multiple entities, if that makes sense.
Yeah, and I guess...
And that allows you to abolish all of this bloat. If you don't
Right.
do that, then you don't get to abolish the bloat and you don't get the benefits of a universal system.
I guess for most people, the biggest question is like, what power does an individual have without quitting their work and marching on Washington and whatever? Is it endorsing a politician? Is it running for office themselves? Is it mailing a letter? Is it, I mean, somebody thought it was shooting an insurance executive, which I can't say that I agree with that. I can understand, I guess, a little bit of frustration, but like most rational people want to look at this with what can be done. And so for somebody that's in the system, I know that you know some of the stuff that Doc Tom's going. I'm going to ask him the same question in a few weeks whenever he's on. And what do we do?
The first thing is that I think it is worth recognizing that you're not alone. The majority of Americans don't like this system, and the majority of Americans are suffering under this system. And the majority of Americans, when polled, want a universal health system. And there are so many things about it that are really good. You would be freed from your job. You could quit your job, not because you don't have to get stuck in it because you have health insurance. You could just be free and go do things that you're passionate about. There's so many other ancillary benefits to doing a system like this that doesn't have to do with medicine per se. So first is just to recognize that you're actually in the majority that you want this to improve. How to make political change in the current era of the United States is something that's pretty opaque to me. I struggle with a lot of apathy around that, and I feel deeply disenfranchised. And I don't feel that voting is a panacea by any stretch of the imagination. But it is the system that we have. And it's worth noting that there are politicians who have plans that are endorsed by people who know what they're talking about. And although there are many ways to structure a universal healthcare system, the one that is the most apt for the United States, because it builds on a system that people already know and like, is Medicare for all. It's a simple slogan, it's a simple concept, and it goes like this. You know that thing that you get when you're 65 where it's not tied to your work anymore and things are just paid for? Let's have it. Let's let everybody have that. There are quite a few politicians who support that. I think it is most notably associated with Bernie Sanders, who is my senator, because I live in Vermont. But there are senators and representatives, Republican, Independent, and Democrat, who support this platform. And I think that platform is the most likely one to succeed. So if you wind up in a situation where you get to vote for it, or you get to vote for a candidate on the basis of this, or you're someone who's willing to call your senator or your representative, tell them that you want that. Tell them what it would mean to you. Tell them how it would either free you from your work or allow you to work because you're on Medicaid and you can't work because your medications are too expensive. And if you go over the cap, you lose your health insurance. Tell them about how it would improve your life, how you'd lose your copays, how you'd be able to have preventative health care, how you want to free yourself and your fellow citizens and doctors and nurses from all of this, and read up a little bit about it. Just understand some basics about how it works so that you can talk about it with people in an intelligent way, because people will have concerns and criticisms. People are afraid about government overreach. They're afraid about losing access to services. They're afraid about supporting people who they don't like. I don't really agree with that criticism, but it comes up. And they're concerned about lots of other things. And there's answers to all of these questions. A simple place that you can go to learn a little bit about this is Physicians for a National Health Program, PNHP, which is a physician-led organization that advocates for this. And you can also just look up Medicare for All and read the position statements from Bernie Sanders and from other public health organizations and politicians about them so that you can learn a little bit about it. I think it's unreasonable to ask every American to become an activist, and I'm skeptical. Even though I have a lifelong history of activism, I am skeptical about activism. So I'm not asking you to change your life. But when you get the chance, I encourage you to speak up on behalf of this and know that you're not alone, and that there are many doctors and many nurses and many other health people and many other just regular people who want a better world, and we can make it happen. It's just about us taking power. And I know that that's not so straightforward, but Medicare for All is the most likely way that that will occur in the United States. And I think it would be a profound transformation for the benefit of almost all Americans.
Okay, I got a question. A little bit different topic, but this is just a frustration that I have, and maybe you can help me understand why it is this way so I won't be so frustrated. How come a doctor's office cannot just tell me beforehand how much something is going to cost?
That's a great question. The reason is because it's totally Byzantine, and there's no way for me to know.
What do you mean? What is Byzantine?
Sorry. It's a giant maze that has. So, for example, there are 1 million health plans, and there are 1 million varieties on each of those health plans. And there's variations on what you're going to get billed and what your copays are and what the bill is going to be. And there's also variations on what's going to happen. And so I just can't know. That's especially true in my environment. It's a little bit more possible if you have a scheduled surgery. Like, let's say you have a gallstone and it needs to come out, but it can wait a month. You may be able to work with the surgeon or the hospital to query your insurance and figure out what your copay is going to be, assuming that the surgery goes well and there's no complications. But in my world, it's just impossible. Like, I don't see someone thinking, okay, that person has a acute left anterior descending myocardial infarction. They're going to need a cabbage because of this other stuff, and they're going to have a postoperative infection and hematoma, and then they're going to lose their job and lose their health insurance. They're going to get on another plan, and that's not going to cover their cardiac rehab. So here's your bill. Like, I just see a terrified person with chest pain. And it is in form of, I cannot tell you how grief-inducing it is as somebody who has a deep love of people and who's dedicated their lives towards helping them, to have someone come in and, as their dying words, are asking me not to do something because they can't afford it.
Man.
Absolutely brutal. Absolutely brutal. You just can't navigate the maze that we've created in real time. And the maze is not an accident. The maze is intended to disenfranchise you and accrue more profit towards the people at the top of this pyramid. It doesn't get me any more profit. I'm not paid on the basis of billing. I get a salary, and if I see a ton of patients, I get paid the exact same amount as if I see one patient. At least in my current employment. I'm not the benefactor of this. The benefactor of this is the insurance and hospital executives, who are usually not doctors. They're usually just bastards, and that are living like parasites off of your suffering.
Mm.
And I think it's common sense that we should abolish that as a society with dignity and compassion.
So, guys, for anybody who listens to this later, I typed into the chat, and I think I got it right. Physicians for a National Health Program.
Mm-hmm.
Is that right?
Yep.
Medicare for All is pretty easy to remember. And I also, I don't want to get political, and I don't agree with everything that he says, but I put in BernieSanders.com because I do agree with the Medicare for All idea, and it is a place that you can go. And ironically, not ironically, I guess, in line sort of with what Kyle said, the caption, the headline on Bernie Sanders' website is "Not me, us," and sort of that sentiment that Kyle had of you're in the majority. Most people want what you want. Most people are disenfranchised with the system. So that website, among other things, is a good place to read about the possibilities of healthcare.
I mentioned Bernie Sanders not because I endorse Bernie Sanders. I have some deep skepticism and disagreements with many of his positions, particularly on foreign policy issues. The point is for sure not about vote for Democrats. Please do not interpret it that way. It's very, very important to me. I don't like either party. I don't think either of them supports everyday people. And the Democrats, as much as Republicans, have played an enormous role in taking huge amounts of money from hospital executives and insurance companies and destroying patients' lives. Mm. So it is very simply not a left-right issue. It is just the better system. Mm. And it is like, if your concern is that you want healthcare to be cheaper, the good news is that universal healthcare is cheaper. Think about it this way. What is cheaper? Buying a window-mounted air conditioner or paying for a 2-week-long ICU stay for heat stroke? If we have a system that prioritizes healthcare, that gives people access, that treats people fairly, that provides fundamental social services like housing and meets people's basic needs, we will have a less expensive healthcare system because we will have a more healthy, less chaotic, less disrupted society. And we will be paying for actual clinical services that benefit real people, not for insurance executives to buy another vacation home while they deny your grandmother access to pneumonia treatment.
Yeah, you convinced me.
This is what happens on weather holds at Skydiver.
Yeah. Evidently, you guys get into some pretty serious conversations over there, bro. You need to chill out.
Tom, yeah, it was kind of echo chamber is not the right word, but just a discussion with some very similar ideas between a couple guys that are entrenched in the system, and I thought, I feel mediumly educated about what's going on with our healthcare. I would say that's probably more than most people have taken the time to do, other than just saying healthcare sucks. My insurance doesn't cover anything. As soon as I ask them for anything, they deny it. You feel like you're paying all this money for coverage, and then as soon as you need the coverage, it's just not there. And so,
that's so stupid.
I just wanted, I guess, again, not to harp on the same point, just that these guys are in the system. They're part of the system. They have as much trouble with it as we do, if not way more.
Well, I think I'm canceling my insurance. This is stupid. This is so dumb.
The great secret of all of these intractable problems that we face is realizing that these are structures that were created by human beings and could just as easily be made by human beings in a different way.
Yeah, that's good. Very good.
It does not have to be like this.
Yeah.
It doesn't.
Nice.
And the path forward is hard. I'm not saying that there's a magic wand that's going to fix it, or if you elect the right person, it's going to be over. Or, in fact, even if we have a universal healthcare system, there will still be deep problems created by the rut that we put ourselves in over the last 50 to 100 years. It's going to take some time. It's going to take a lot of work, but it is totally doable. It is absolutely possible to have a world in which you call your doctor and someone picks up on the second ring and fits you in and helps you solve a problem. It's absolutely possible that when we spend our money not on murdering innocent people around the world, but on taking care of each other and maintaining lives of dignity for all people. This is a totally real thing. It has happened. It just hasn't happened here.
Yeah. Yeah. Well, JRuss, we're at an hour. If you've got more questions and you want to keep going, that's totally fine with me. I want to hear if you have any experience like helping people in like emergency stuff, like in skydiving. Have you had an opportunity, or not an
For
opportunity? That's
sure.
probably not the right word. Not
For
opportunity,
sure.
but yeah. So is that okay, JRuss? Can we? And then also, JRuss, there was a fatality last week. Did you know about that? That I think we need to at least bring up and talk about, because
Okay.
the situation, it was really terrible.
I don't know if
So
I've heard about it. Okay.
okay.
But Kyle,
So Kyle, yeah, any
Oh, for sure. I've treated people skydiving. I am going to struggle a little bit with what to say, because part of me wants to share stories because they're compelling and they're fun. But it's also really important to me to protect the privacy of the injured people, and I don't have their permission to talk about their cases here.
Okay.
And this is a skydiving podcast, so it's possible that it would get back to them.
Yeah.
So I will say, every Summerfest, I'm being a doctor, or at least every Summerfest I've been to, and most boogies that I go to, I'm working as a doctor. And that happens when I'm just fun jumping. I have a few thoughts about it, and although we have not largely been talking about safety and emergency training, I think it's maybe worth saying a few words about that. The first thing I want to say is, if you're a skydiver, or if you are in something that's even higher risk than skydiving, like you're a paraglider or base jumper or speed rider or speed flyer, it would be a rare person who has a career in those sports and does not either experience or see some significant blunt force trauma. And we do not rise to the occasion. We sink to the level of our training. So get some training. A wilderness first aid course or a wilderness first responder course is really, really valuable. A wilderness first aid course can be done in a day. A wilderness first responder course is longer, but you will learn a lot. It will protect your friends. It will make you feel comfortable, and it will help you out. If you are a skydiver, and this is a skydiving podcast, so I'll focus on front country medicine. I'm going to assume that you're at a drop zone where you can call 911 as opposed to on a cliff or a bridge or in the sky in some other fashion. The first skill of every emergency medicine response is to observe and to stay calm. These two things go a long, long way. There are many ways that we teach residents about this. A common emergency medicine line is that the first step at a cardiac arrest is to take your own pulse. But the idea is to ground yourself and to calm that adrenergic response, that adrenaline rush that you get that makes you want to immediately engage with the incident. If you run up there and suddenly you're in a bunch of canopy traffic and you get taken out by a tandem that you ran in front of, you have now created more trouble. And maybe that swooper bounced and something got ejected from their foot and it impacted some grandpa's head who was watching in the stands who's on a blood thinner. And maybe that person's actually more critical than the skydiver who just sprained their ankle. So observing is really helpful. And observing is very grounding. So for example, when I am in the emergency department and I start hearing screaming and chaos and the sounds of feet and people begging for help and a lot of noise, my first thought is, airways open. Sounds like they're thinking. Those are two good things. Their brain's working and they're breathing. Okay, awesome. Okay, I heard 2 feet. Maybe there's 2 patients. Then I walk up there and I observe. So take a second and calm yourself down. Being calm is really, really powerful. Patients need calm. The second thing is organization and communication. Pre-hospital patients who are critically ill generally do not live or die on the basis of sexy, high intensity emergency procedures. Although, for sure, if I'm at the scene of a blunt traumatic cardiac arrest, I'm going to enter that person's chest and do a bunch of pretty hardcore stuff. They survive because of communication and teamwork. So organize yourselves, figure out who's going to approach the patient, who's going to call 911, who's going to figure out what the patient's needs are, who's going to figure out how to extract the patient. Then go to the patient, calm them, keep them warm, keep them informed, and go from there. Usually at that point, you can get a plan together. That's very, very basic, and you will learn that in much greater detail if you go to the effort of taking a wilderness first aid course or a wilderness first responder course, which I strongly encourage people to do. But it will help you so much. If you are jacked and breathing hard and running around, that is not going to be effective, and it's going to stir up more anxiety. What patients really need is confident, clear leadership, and they need to have communication, and they need to stay warm.
Awesome. Do you think that there's something that would it be worthwhile to at some point in the future put together like some sort of crave course on? Is that something that would actually help people, or is it something people need to go take a course in person, something like that? Do you understand what I'm asking?
I do. I've thought about this a lot. I'm not sure I know the answer. I have been thinking for the last couple of years, ever since I got really obsessed, initially with paragliding and then with skydiving, about how I can contribute towards people's safety. Mm-hmm. I've taught a couple of courses. I went out to Moab and taught a trauma lecture to base access during Turkey Boogie last year. And I think things like that are helpful. There is a lot that you can learn didactically through something like a course.
Yeah.
But there really is no substitute for getting your hands on people. There are some like really fundamental skills that are useful to learn in person, like how to touch someone, how to approach someone, how to remove a helmet, how to get someone out of a rig, how to drag someone by their rig if you have to. But there's a lot of knowledge that's really helpful. Like, should you do CPR or not? The answer is, in most traumatic cases, it is probably not. Should you protect their spine or not? And that's a complicated question that often the answer is to focus more on their overall clinical concerns, if those things are critical, but you may or may not want to do that. And it's not that hard to understand whether or not someone really needs that. A lot of those things can be learned in a lecture basis.
Good.
Anything people can do to gain a little bit of knowledge is helpful. I would say that if you're in love with jumping and you plan to spend a lifetime in the sky, I would be shocked if you're not first on scene for some pretty brutal trauma at some point in your life. Yeah. Hopefully it goes okay, but it's really, really likely to happen to you. Yeah. And you are going to be so proud of yourself and so grateful for any knowledge that you have. And if that's from reading a book or watching a course or going to a course, whatever it is will help you.
So it sounds to me like Kyle's giving a seminar at Summerfest next year.
I mean...
Start prepping for that now.
Kind of sounds that way.
I would be honored to do anything I can to help our community.
Yeah.
Okay, Chris. Let's. I don't know if I'm aware of a fatality, but I do want to touch on that before we stop. Do you have details?
Yeah, some. I mean, not firsthand from talking to anyone who was there, but people who. So apparently. So one group exited the plane and they were flying, and then someone from a group after them evidently tracked up or down, whatever, up jump run and collided with someone else who this person was, they were doing like outside camera for this group. So they were flying camera. Someone from the group after them tracked up jump run, collided with them. Evidently they were both knocked unconscious and just went in. Well, they both had AAD fires. Apparently, from what I have been told, they were both seen under canopy in that short amount of time. I don't know how they were both seen because that seems like they would be super low. But the report was that they were both unconscious under canopy. Again, I'm not sure how people would see that. I mean, AAD fires, that's, under 1,000 feet. So the one guy, so person A who was hit by person B, right? Person B tracked up jump run and hit person A. Person A died. And person B, who was the person that was the one that tracked up jump run, they apparently had a broken bone, from what I understand, and basically, and survived. So I think, you know, that's secondhand information to me. I do know that there was a fatality. That is confirmed because I know the person who actually passed away. They're from this area. It didn't happen in this area. It happened in another state. But just knowing jump run, knowing where other groups are going, knowing where you're tracking. These are things that we've talked about over and over and over. It's just so easy to make a mistake. Like, you just got to pay attention. You've got to get input from other people. Like, you got to ask questions and figure out. If you're not confident, just don't do it. JRuss, go ahead.
Well, there's a couple things that come to mind, I guess. The first one is that I honestly, I feel for the person who passed away. I don't know if I know who it was, and I'll probably feel more if I do know that person. But I also feel for the guy that fucked up, because I think most of us, given the choice, if we can make a mistake and get hurt ourselves, or make a mistake and hurt somebody else, probably would choose option A.
Yeah.
And I think that's pretty universal. And so he's gonna finish with his injuries, and then he's got to deal with that for the rest of his life. And I don't know. I guess maybe if you were a sociopath, you could put that aside, but I think most normal people, that's going to be a struggle for him. So I feel bad on that count.
Yeah.
I think it's interesting is not the right word, but that's the one that's coming to mind. Just that I usually stop my seminar. I gave intro to angle seminars every day except the last Sunday, and 2 or 3 days I gave it twice. And there's a part of that where I'm trying to communicate to people the fundamental things they need to know to start angle flying. And there's just a whole world of knowledge about any discipline that you choose, and it's tough because people are drinking from a fire hose in that seminar. But I've whittled it down about as far as I can in my mind that you have to know these things. And one of them is a quick discussion about, have you jumped at another drop zone where you went on an angle jump? And, of the beginner people, if I've got 20 people, 2 or 3 people put their hand up and say, yeah, I've been on an angle jump at home. And I'll say, have you ever heard someone say, hey, we're going to go up line of flight? And almost always they say, yeah, that's what they said. We're going to go up line of flight for some period of time to collect people, and then we're going to make our turn. And I can hardly disagree with that any more than I do. And the reason that I give, and I don't know if this is as intuitive as it seems to me, is that after 20 some years of coaching skydivers, you just don't know what your student is going to hear. And you don't know when their mind is going to go somewhere else. And if I say to 3 or 4 people, hey guys, we're going to get out of the plane and I'm going to go up line of flight. And in their mind they go, oh, line of flight, I think jump run is 270 today with a 0.6 prior. And they miss the part that comes next and then we're going to make a 90-degree turn and we're going to turn off line of flight. But they were thinking about what line of flight even means. And they didn't hear anything I said for the next 5 seconds. Okay, so there we are, going our direction and blah, blah, blah. And now they tune back in and they're cool. And then I asked people, how many people in this group, how many have fucked up your exit? How many are going to come off the plane perfectly right now? And just gets a chuckle and yeah, people, I've messed up my exit. And I'm like, man, I don't know how many exits I've messed up, me personally, but a lot. And did you do a somersault? Did you do a flip? Did you do a barrel roll you didn't mean to do? And when you came out, did you know where the organizer was? But did you maybe think, oh, but I know the direction we're going, and so I'm just going to go that way. I don't know where the organizer is at this moment. I'm a little disoriented. And guys, that's a fucking disaster waiting to happen. That's I know that he said we're going up line of flight, and my beginner angle person says, I don't know, I know jump run was north, so I'm going to go up line of flight, and hopefully I catch up with them, and I'm just going to try hard. I don't ever want to even use those terms. I don't want people to hear that come out of my mouth. I want to say I'm going to hold my heading for a second, and then I'm going to turn pretty quickly, 90 degrees perpendicular, because my heading is a very nondescript way of saying I'm not going to turn immediately. But I'm not saying that's what happened in this scenario, but my emphasis over and over and over in those courses, seminars, whatever you want to call them, is we are not going to go up line of flight. We're not going to go down line of flight. There's never a time in my world where those things are okay. I've argued with limited success with friends of mine that run Fly for Life. You know, Luis has been a friend for 20 years, and we used to angle fly together when both of us had 500 jumps and didn't know what the fuck was going on, and we went really fast, and by the time the end of the jump, I didn't even know where I was. And Sharon, who's a really good friend as well, I've said these words to them, and I think they still are using, we're going to collect people up line of flight. And I hope that will migrate out of the verbiage that we use for teaching people how to angle fly. So the quick thoughts that come to mind there. And with more details, maybe I'll have something else that I want to say, but that's all I got. That's all I got.
Yeah. Well, so that's the details that I know, and I mean, it's just rough to think. I mean, something so, it's terrible,
Yeah.
It could be, but I think that's just it's good for us to hear and to talk about those things and remember that it really is easy to make those kind of mistakes. Like, we've got to be working together, we've got to be paying attention, we've got to be like quizzing one another, asking questions, like helping each other stay sharp and stay on top of these things. And don't get offended if somebody in the loading area is asking you, hey, what are you doing, where are you going, what's your group? Like, those questions are not offensive. Those are good, helpful questions. We need to be making sure that everybody knows what they're talking about and what they're doing in the loading area. And if somebody, an organizer, or even a brand new jumper, it doesn't matter who they are, if they're asking those questions, they need to know, they want to understand, they want to learn. And if you don't know the answer, don't get mad and frustrated because they made you look dumb. Dude, just figure out the right answer and do what you got to do, right? Like, man,
Yeah.
it's not
I heard from Nicholas that we had on a few weeks ago, the Chilean crew that came up with the angle fly program, and I really feel strongly that one of the things that's missing in our community is just some basic structure, guidelines that people can follow, a body of knowledge that's not closely guarded because there's financial incentive to keep that to yourself, but instead caring for the safety of the community at large. And I still think that there's plenty of camps that can be run and skill sets that can be improved and information that can be disseminated that a basic structure would not take away the income stream of people who make their living by teaching angle flying. I think it's still an incredibly popular discipline, and just having some, I'm really looking forward to sitting down with Melissa when we get that document from them translated to English and going over it and saying, how can we apply this to the USPA so that people just have the nuts and bolts of what we're doing, and then the coaches can still make their fortunes on the nuance, but we need some structure.
Yeah, that's good. That's good.
Okay, so Kyle, you familiar with some show podcast where guys say at the end, "You've wasted a perfectly good hour"?
I'm sad that you said that, because I was going to interject and say that you've done it again. You've wasted another perfectly good hour on the Crave Show with JRuss, Chris, and Kyle Barbour.
You guys set this up beforehand?
I love it. See, when it's not my turn, I don't get to say it. You said it for me. Thank you, Kyle.
I had never heard that prior to this show, so I'm just going to assume that it's a Chris Fikes Crave Show original. And I will say that I've listened to pretty much all of the Crave episodes, and it makes me laugh every time.
Very good. That's good.
All right. Well, I think
sorry, JRuss.
It's okay. This debate will be ongoing, and this is bigger than you, Kyle.
Yeah, that's awesome.
Yeah. So everybody, thanks for joining us. Hopefully, this has been educational, informative, and stirring. It's our healthcare, and this is exactly what I want to talk about. And sorry that skydiving took a backseat to a larger discussion about something that our society desperately needs. So, Kyle, thanks for sharing a bunch of wisdom with us and some perspective from, honestly, the other side of the fence that a lot of people don't get to hear. And that's what I was super hoping for out of this podcast, and I think that we delivered that up very well. Thank you, or you did.
It was. It's always delightful to spend time with you, and I'm glad that we got the chance to chat a little bit. And I hope that in some small way, this contributes to making a better medical world for everybody. I do truly. I know in my heart, and I have seen it in reality. It can be done. It is not a pie in the sky fantasy. It is a real thing that has been implemented by real people, and we can do it too.
Yeah, I want to believe that there's a critical mass coming, and that eventually
change is coming one way or the other. Whatever is happening right now does not feel very stable to me. Mm-hmm. I cannot imagine that this is the next 1,000 years. Something is going to change.
Yeah, I don't think it'll be this conversation as a unique thing, but this will join the collective consciousness of we need change in this country. So, So for our normal skydiving listeners, I can't say that we're going to resume skydiving because the next two guests that I have in mind, I think are, well, maybe, but we'll see. They're skydivers, but we might be talking about other topics again. So sorry for the deviation, but we're not locked into a script. So hopefully you guys liked it. And,
That's right.
And if you did,
if you don't like it, don't listen.
Yeah, it's JRuss's fault. Chris didn't have anything to do with
it. We talked about movement safety. That's like the core Crave topic.
Yeah.
That's right.
It has become that. Awesome. All right, guys. So thanks very much, everybody, for listening. And Chris, thanks for hosting. And Kyle, thanks very much for taking an hour and a half out of your day and educating some skydivers.
Thanks, Kyle. That was fun, man.
So, you want to say the Crave part? You love that. You love that part.
Who, me? You say it.
All right,
Kyle say it.
Kyle?
I don't know exactly what
he doesn't know what to say.
I actually don't know what you're talking about. So
This is Chris's favorite part. Get out there with your friends, enjoy the sky, enjoy your time with them, live in the moment of that wonderful skydive that you get to be a part of, and try to keep in mind the motto of Crave, which is do more and be better, and enjoy all those moments with your friends.
Yeah.
Thanks, guys.
All right. See you guys.
Cool.
Bye.
See ya.